Okay, so for some reason, my computer will not let me present and share at the same time. So I'm just going to share from a little bit smaller view. Um, but this is my clinical presentation. I was on 7 West at Essentia, which is a med surg floor. They specialize in abdominal surgeries, stomach diseases, and burns, which we saw a lot of like appendix surgeries, perforated bowel, other bowel issues. And the population on the floor was a lot of like elderly people. There was a lot of like a geriatric population. However, there was a few patients that seemed to be like within the 30 to 40s range, but it was a lot of like elderly patients going through various diagnoses. So my preceptor was Tristan Sunfelder, and I was in the Tuesday clinical. So the situation is my patient DL was admitted. He is a 78-year-old male. He was admitted from Deer River, Minnesota Emergency Department to Essential Health by ambulance on 11/16/22. He was in the emergency department with acute chest pain, chest and abdominal pain. Upon arriving at Essentia, he had to undergo a surgery for perforated viscus, also known as a perforated bowel. This patient is a frequent hunter and fisherman who enjoys the outdoors, reading, working with various metals and woods. Currently lives alone and is estranged from his 2 daughters and his ex-wife due to his battle with alcoholism in his earlier life, which we will get to. He has a close relationship with his brother, who will be providing care for him upon discharge. The illness is impacting the patient because it can increase his ability to contract an infection and create further problems down the line, preventing him from doing things that he enjoys. Also, upon all of these new diagnoses and the things that he's been experiencing, the patient has concerns about going home and about his brother taking care of him. So there is a new developed within his care plan to get him assessed to go to a short-term or long-term rehab center to get the proper care that he needs upon discharge, if that's within the near future. Goals for this treatment is to get that GI um, obstruction, the abdominal obstruction with his bowel fixed, that resulted in a leakage of toxins into his peritoneal cavity through the wall of his GI tract. So that's where he's experiencing a lot of that abdominal pain radiating up into his chest. So we also need to manage his diabetes. He is a type 2 diabetic. He needs to manage the cirrhosis of the liver, which is a new diagnosis that has been impairing his kidney function, and to manage some hypertension that he's been dealing with for a while as well. So some nursing concepts that I gathered from this information is risk for poor wound healing, risk for dehydration, risk for bleeding, risk for increased susceptibility to falling that may cause physical harm. I will get into the nursing diagnosis concepts, how they relate to his symptoms in the next couple of slides, but I just kind of wanted to introduce them to see kind of what we're dealing with and what we're looking at. So for his health history, he is a type 2 diabetic. He has cirrhosis of the liver. He has an acute kidney injury impairing his kidney function. He has hypertension, hyperlipidemia, stage 4 prostate cancer, depression, and arthritis. He was a former smoker from age 15 to 35, smoking 1 pack a day. Has since not smoked. Recent alcohol issues from age 13 to 60, which he has been sober since age 60. He did not indicate how much alcohol was consumed periodically. He was unsure. There was a lot of alcohol, which has resulted in the liver and kidney issues. So I'm just going to go ahead and assume it was a lot. Estranged from his ex-wife and his 2 daughters, so he does live alone. He's got some family history of heart problems. Specifically, his father had hypertension, cardiovascular disease, and he died at the age of 64, which is pretty young. His mom had some polycystic kidney disease issues, along with a blood disorder, congestive heart failure, and she died at the age of 84. So we're seeing kind of a trend in his family history with heart problems. So that kind of looks into the genetic makeup and how he could be developing further heart problems down the line, especially due to these diagnoses with that he's been going through right now. So he has a surgical history. He had a urethral stricture dilation, a TURP procedure, a cystoscopy, and a bone marrow biopsy in previous time. Today, his surgical care consists of that laparoscopic procedure converted to a laparotomy for a modified Graham patch for that perforated prepyloric ulcer repair. So that resulted in an abdominal scar, a Foley catheter to be placed, a JP drain in place, two peripheral IV sites, a DigniShield rectal drain, and NG tube. So upon assessment, we have some labs here. Some labs that correlate with this are that high sodium, high BUN, high INR, high protein, and high albumin. And then we have some low PLT hemoglobin hematocrit levels. So I put only the ones that were out of range, especially want to indicate that high sodium, because that goes for a risk of dehydration. The albumin, he's actually on a supplement for, he's on an albumin IV supplement for, because of his levels. I did not get the actual level of the albumin. I forgot to write it down, but it was way out of range. Actually, I take that back. His albumin was high, so he's on a medication to decrease his albumin. That's what it was. So in that head to toe assessment, he had a loss of voice due to dry mucous membranes, visibly tired. He's visibly tired with the vital signs of 113/65 for BP, temperature of 36.8, a blood pressure of 80, and respirations of 16. He's a bit forgetful, but able to reorientate to time and place. He says he's just starting to forget things because he's been in the hospital for so long, which is understandable. Pressure sore newly developed on his coccyx. He has a surgical site wound. His dressing is dry and intact. Hypoactive bowel sounds in all 4 quadrants. Normal heart sounds. Cap refill is less than 3 seconds. He has visible bruising on his arms. Tenting of the skin indicating dehydration. Laceration on his hand with the dressing dry and intact. The laceration happened before admission, so he came in with that, which has been good with the wound healing. He does have pain in a scale of 6 out of 10 for gassy and like bloating pains in his abdominal region. So far, we have some things that are ordered. We have a swallow function test ordered, a CT scan. He was previously getting paracentesis procedures where they would go in and put a needle into his abdominal cavity where they would find fluid and take that fluid out. Before, they were taking a lot of fluid out, so they were continuously doing it like every 2 days, I want to say. And he had one earlier in the shift, and he only got 9 cc's of fluid out, so they thought it was not necessary to continue doing this. There was not any more signs of fluid buildup in the abdomen, so they discontinued those procedures for the lack of fluid buildup to prevent any more like harm to his abdominal cavity than they needed to. He does have a current weight loss of, he started at 184, now he's down to 167. He's MPO with ice chips due to that, having that NG tube in place. And that pressure sore that is developed on his coccyx has been evaluated and assessed, and proper dressing has been put on since the assessment, but they are concerned because it is hospital acquired. All right, so I just kind of related the concepts a little bit. So that poor wound healing is related to his decreased circulation, and that's evidenced by that poor diabetic management, loss of sensation, and decreased skin integrity. Dehydration related to dry mucous membranes, evidenced by loss of voice, low urine output, dry mouth, and that tenting of the skin. And I indicated some of the medications that he's taking that are relevant to the symptoms and stuff that I'm talking about. So that furosemide is that Lasix diuretic that's gonna get rid of that fluid that's been building up. So we're gonna use that to treat edema with CHF, cirrhosis of the liver, and renal diseases that are newly developing with his kidney injury, his liver disease, his other issues that he has going on. So some side effects of that are excessive peeing, feeling thirsty, dry mouth, headache, dizziness, confusion. The problem with this one is that he has a low urine output right now, indicating that dehydration. So we are concerned because with taking that LASIK, he should have a higher output. However, he doesn't. So that is something that's being assessed. The gabapentin is for nerve pain. Some side effects of that would be like feeling sick, nausea, vomiting, mood changes, swollen arms, dry mouth. And the problem with the furosemide and the gabapentin that I saw right away was that dry mouth. And my patient has extremely dry mucous membranes, and the water is pulling out, but there's low urine output, so it's a little bit concerning. He's got dry mouth, so he lost his voice. He has that NG tube in, he's MPO. So there's just like a lot going on, but those are two things with the dry mouth that I noticed right away. And the heparin, he's on 5,000 units of this anticoagulant to prevent blood clotting and other things, but some side effects could be abnormal bleeding, sneezing or coughing too hard, or blood in the urine, things that could cause a previous clot to break and cause bleeding. There's visible bruising on the skin, so we want to kind of monitor that as well. And heparin has some issues where you could feel weak or thins your blood too much if your blood levels are low, especially with low hematocrit and hemoglobin. So that's something we want to monitor to prevent falls. So then we are going to get into my recommendation and response. So I have come up with these 4 nursing diagnoses with interventions as my recommendations. And then I'll kind of talk about them and our outcomes. But I'm going to talk about each one of them kind of differently. And I pulled these all from my CRM. I don't have my CRM with me. I was going to bring it for the presentation, but this is what I got. So for the first nursing diagnosis, the risk for poor wound healing, decreased circulation is manifested by poor diabetic management, loss of sensation, and decreased skin integrity. So things that we can do to help that are repositioning every 2 hours, providing a moist environment with proper dressings, and providing nutritional substrate to enhance the healing process if those nutrients are low for wound healing, and proper fluid intake. The smart outcome that I put with that would be that proper diabetic management has led to no more skin breakdown, proper fluid intake, and decreased risk for pressure sore. And the time period that I put on this outcome would be I would say probably within the next couple of days, because they have to take time to get that insulin regulated, and taking a whole thing about it's a manageable outcome. However, it's not going to happen in a day or in 2 days. Like, his skin integrity is going to take time to rehydrate, regain elasticity, stuff like that. So it's going to take some time, but hopefully by the end of the week is the time frame I'm going to put on that outcome. But for the nursing diagnosis of risk for dehydration, we have those dry mucous membranes evidenced by loss of voice, low urine output, dry mouth, tenting of the skin. And some interventions we could do for that is encourage and remind the patient of oral intake of the ice chips, administering IV fluids as needed, educating the patient on dehydration symptoms, and replacing electrolytes as needed. My smart outcome for that was a little bit easier. Proper fluid intake has decreased symptoms of dehydration by the end of the day. Dehydration is something you want to take care of right now. We need to get that under control. It can cause further problems, especially with diabetic patients. So we don't want to fluid overload them, but we don't want to dehydrate them. So we need to intervene today by the end of the shift. For the third nursing diagnosis, risk for bleeding. Increased chance for bleeding due to that low red blood cell hematocrit and hemoglobin levels. Use of that heparin anticoagulant, like I said earlier, there's a lot of issues with that. So it's some interventions would be using a soft toothbrush to avoid like not getting your gums bleeding, avoid rectal suppositories, enemas, thermometers, anything that can cause a pre-existing clot to break or for a new existing bleed to occur. So avoiding forceful coughing, sneezing, and blowing of the nose with sharp objects, frequent lab draws, and proper documentation of bruising, of any newly developed bleeding or onset of internal bleeding that you might see needs to happen today. This is an intervention that we have to be very careful of. Although this intervention is something that needs to be documented today, an outcome for this would be that the lab values are within normal range by tomorrow, because we want to take care of that dehydration and other issues to increase those lab values. The lab values were showing high sodium levels, so helping, excuse me, the dehydration will rid of some of that sodium, and hopefully by tomorrow, with the proper fluid balance and intake, then we can help with those other risks that are involved. So normal lab values by tomorrow increase that bleeding chance. The last nursing diagnosis related is risk for increased susceptibility to falling that may cause physical harm. This patient is already a fall risk. However, they are not moving. They are not trying to get out of bed or do all these things due to weakness and other issues, but this is related to that altered mobility secondary to that unstable gait due to weakness, manifested by recent surgical procedure, newly developed pressure sore on that coccyx, disorientation to time and place, increased blood pressure, low urine output indicating dehydration. So when this patient has risk for bleeding, risk for dehydration, poor wound healing, if they're going to be up and trying to move around, this is going to cause a major safety hazard for them. And things need to be implemented so that they don't cause further harm by falling in the hospital. So some things we can do are exercising programs to help just improve his balance, gait, strength. Withdrawing or minimizing any psychoactive medications that may cause him to be more weak or more out of it when he's trying to move around. Management of his orthostatic hypotension, foot problems, footwear, proper footwear, making sure his home environment is safe, and also using assistive devices or to assist or implementing a care plan of like a bed alarm or something that's going to help this patient not fall and cause further harm with other symptoms that they have going on. So smart outcome that I came up with for that was interventions have increased safety by the end of the shift. So what that means is that our interventions of maybe getting a bed alarm or getting him on a physical therapy program or getting proper footwear, assessment of the home, stuff like that. These are all things that can be implemented today. And the things that we can control as far as assistive devices and stuff like that, we can implement that today to decrease the risk of a fall and increase the safety for that patient. So that's something that you want to focus on by the end of the shift so we don't have any other further harm to the patient. So my reflection is this allowed me to see a lot of like new medical equipment and their proper uses by medical staff. I know we see a lot of these this equipment and stuff. We see it in movies, we see it in books, we see it in class lecture, but we don't see how it's used by a nurse in that situation in the moment. So seeing all this technology and all these different procedures being done in the hospital during clinical was really like mind-blowing almost, because it's like you see and you learn and you do all these things, but to see it in action is totally different. I got to administer some medication through an NG tube and give injections, so that was really cool. We were just briefly introduced to NG tubes in labs, so like going into clinical and being able to walk through it with my nurse and give medications through the NG tube for this patient, giving that heparin injection, stuff like that, really kind of like boosted my confidence in just like the skills that I was doing. Um, it allowed me to be more comfortable with my practice and approach like patients holistically, and provide good clinical judgment with like communicating with the patient, taking my assessments as needed, involving the patient in like my learning experience and like what was going on. And I would correlate the Benedictine values of love of learning and respect is because I gained knowledge through the new atmosphere of clinical and the situations of the patients. And these values allowed me to have better clinical judgment throughout my clinical days and experience as a whole, especially with the patient, with communicating, respecting them, their history, their family situation, and just kind of putting that all aside and just having respect for them and caring for them and enjoying my learning environment and taking in as much as I can to learn something new. So I really enjoyed my clinical time and I really enjoyed getting to know my patient and seeing like all these new devices and things that could be used throughout the hospital experience. So that is the end of my presentation. Thank you for watching.